Hello everyone, a very good evening. So, as a part of a Plan C Plus English edition, we are having this regular Friday power-up sessions which is exclusively in English and targeting the English audience who is preparing for NORCET examination. And I welcome you all to the next Friday power-up session. And again, this session is reinforcing about the most important hot topics which are probably asked in your examination, right? So today also we have a very important topic, and anyway there will be 1 or 2 MCQs, even 3 MCQs comes from this particular topic. Any guesses for the topic? A very good evening, Dharmaraj, Priyanshu, Chiku, Ankita, Sonia, Pooja, Christina, Muva, Mano, Shabana, Manoj, Priya, Anishwa, Swati, Sharat. A very good evening. So today's topic is atrial blood gas analysis. So a very important topic. You need a core understanding to do an ABG analysis and interpretation. And as you all know, 1 or 2 marks is also very important in your competitive examination. So that's why we have this session now. So what is the expansion of ABG? That is your arterial blood gas analysis. So as you all know, ABG works on these important top priority parameters. This is a very basic thing you have to remember. That is the normal values, right? So the pH, which is very easy, it is 7.35 to 7.45. The normal pH is 7.35 to 7.45. Your normal PaCO2, just remember about the pH. You can easily remember about the PaCO2. Just drop this 35 and 45 down, and the unit is very important, that is mm of Hg. Next we have the HCO3 component. That is a base component, which is the normal value is 22 to 26 milliequivalent per liter. Additionally, you can also learn about the PaO2, that is 80 to 100, and SaO2 is 95 to 100, and base excess is calculated in -2 and +2 milliequivalent per liters. And come back here, the degree of metabolic compensation will be evaluated with base excess only, right? If it is -2, it is indicating negative, that is acidosis. If it is +2, it is indicating basic, more basic, and positive basic, which is indicating alkalosis, right? Yes. So the most important thing will be discussed now. So what are all the steps in interpreting an ABG? We have many steps in interpreting the ABG. So first, you have to follow these steps. First, you will be identifying the normal values. So step 1 is identifying the pH. The pH, either it is acidosis or alkalosis. As you all know, when the pH decreases, we term it as acidosis. We term it as acidosis. On the other hand, when the pH is increasing, we term it as alkalosis. Alkalosis. Am I right? And the normal pH is 7.35 to 7.45. And when it is decreasing, we are terming it as acidosis. When it is increasing, you have to remember increasing, which means very big in size, like a Hulk. So it is alkalosis, right? And step 2. Step 2 is either you can use the Rome, or I have a similar principle. I will show you. When the pH and your PCO2 goes in same direction, which means if the pH is increasing, PCO2 is also increasing. If the pH is decreasing, PCO2 is also decreasing. This case, we are terming it as metabolic problem. It is a metabolic problem. It is a metabolic problem. So remember the same M, and remember it is a metabolic problem, right? When the pH and PCO2 is moving in reverse direction, right? So then the problem is, remember this R, reverse, remember respiratory. As per your ROMs, when respiratory is opposite, metabolic is equal, right? When your HCO3 and pH is going in same direction, you are terming it as a metabolic problem. When your PaCO2 and pH is moving in a reverse direction, you are terming it as respiratory. So this will reduce your confusion, and this is very, very important. And whenever the problem is in the respiratory system, when you find out it is a respiratory issue, never ever, no need to see the HCO3 level. You don't have any component to see the HCO3 level unless until the question is indicating that you have to analyze the compensation. Right? So when you found out it is a respiratory problem, you are concluding it. So next, in advanced cases, they are asking about the compensation. In advanced cases, they are asking about what? Compensation. If there is a metabolic problem, obviously you have to see the respiratory compensation. So remember, when the pH is becoming normal, ultimately what is the importance of compensation? You tell me, what is the importance of compensation? Like when an acid is getting increased, right, the base has to work on it to make it stabilized. Okay, when the patient is going for acidic state, there should be enough base to make it more at the level of compensation. So that is what is happening here. When there is a metabolic problem, when the pH is becoming normal, ultimately if pH is becoming normal, the proper compensation, the acid-base metabolism is cleared. So that is termed as pH is normal. When the pH is normal, that is fully compensated. When the pH is normal, we are terming it as fully compensated. When the pH is not normal, in that case, we are terming it as partially compensated. Or if the problem is in the metabolic state, then you have to think about what component? You have to think about the respiratory component. Then you have to watch the PCO2 level. If the PCO2 level is normal, which means I'm not doing any work to reverse the compensatory state. So what is happening? It is again uncompensated. The same thing is applying for your respiratory status also. If the thing is a respiratory problem, so the same thing is going to apply here also. Just remember, when the pH is normal, then it is fully compensated. When the pH is not normal, then you are indicating it is partially compensated. In case of the problem is in respiratory state, so you have to see the kidney's compensation in excreting the bicarbonate, right? So what you have to see? So here, when the HCO3 is at the normal level, then you have to identify it as uncompensated because kidney is not trying to do any form of compensation. So these basic rules is very, very essential in order to clear any form of ABG MCQ, right? So coming back to the first step, you have to identify whether it is acidosis or alkalosis. So the pH is normal is 7.35 to 7.45. If it is less than 7.35, you are telling it is acidosis. And if it is more than 7.45, you are terming it as alkalosis. Then you are coming to your Rome classification, or you can follow this classification. Remember about pH and PaCO2. When pH and PaCO2 is going in same direction, you have M in same, it is metabolic problem. When the pH and PaCO2 is going in reverse direction, when the pH is increasing, PaCO2 is decreasing. When the pH is decreasing, PaCO2 is increasing. In this case, if it is going as a reverse direction, then the problem is the respiratory problem that you're going to identify, right? So now coming back to the compensation analysis, in case of metabolic state, please remember this rules for compensation. It will be very, very easy for you. So in case the problem is a metabolic problem, your concentration will be on the pH as well as your PCO2. Whether the lung is doing any activity to do the acid-base metabolism to be compensated. So that is the action which we are expecting here. So here, when the problem is metabolic, you're going to see the pH and PaCO2 level only. So what you are seeing, if the pH is becoming normal, so lungs has done a very good work. It has been working to make the pH to be normalized, so it is fully compensated. Then, if the pH is not normal, there is no enough action. There is no enough action of the lungs in maintaining the metabolic state to be normalized. So here it is in the partial compensation process. When the PaCO2 is normal, in that case, it is not doing any action, right? Either it is not increasing, either it is not decreasing, it is at the level only. So in that case, what we are telling, it is completely uncompensated. The same case is applying for respiratory system. In respiratory system, you will be thinking about HCO3. And along with this, I would like to teach you certain important basic elements which is very, very essential for going for the examination. See, listen, we are talking about acid-base imbalance, right? So what is the acid? What are all the components is the acid? You talk, your CO2 is an acid. Your CO2, your carbon dioxide which you are inhaling is an acid component. Then your hydrogen is an acid component. The hydrogen which is excreted by your urine is an acid component. That you have to remember. On the other hand, what is the basic component? The base component, B base, so your bicarbonate which is reabsorbed by your kidney is a basic component. This you have to definitely remember and by heart. Remember, acid component is your carbon dioxide and your hydrogen ion, whereas your basic component is your bicarbonate, which is reabsorbed in your kidney, right? So again, in compensatory, the most important thing you have to notice, for example, my body is going for metabolic acidosis. My body is going for metabolic acidosis. So what is the expected compensatory mechanism I am expecting? Now tell me in the comment box. Yes, very good, Divya. Now tell me in the comment box, if the problem is metabolic acidosis, what kind of compensatory mechanism you expect in the body? Yes. Whomsoever is answering, yes, the problem is metabolic acidosis. So what is the compensation you can see? Very good. Please give a big round of applause to Divya Rubini. Very good. See, listen, always remember a very, very easy concept. Whenever there is like this metabolic acidosis is not that much clear, let me write in the new page. Right. So now we are talking about compensation. So I said you the problem is metabolic acidosis. The problem is metabolic acidosis. Whenever you see such things, just go opposite. See, Divya, Nikita, and Batishpa, Shrabi, and Shrishti, many of you have answered correctly. So listen, whenever there is a metabolic acidosis, the body's compensatory mechanism is respiratory alkalosis. So how you have to remember is, please be very easy. It is very easy. Metabolic opposite is respiratory. Acidosis opposite is alkalosis. That is how you have to think. It is very simple. Whenever you see metabolic acidosis, what is the expected compensatory mechanism? It is respiratory alkalosis. And whenever it is metabolic alkalosis, what is the expected? Now tell me in the comment box. Now tell me what is the expected compensatory mechanism which is happening in metabolic alkalosis? What is the expected mechanism which is happening in metabolic alkalosis? Yes. I'm waiting for your answers. Yes, I will talk about CO2 washout on all. Yes, obviously. Please give a big round of applause to Priyanka and Sharma and Divya. It is your respiratory acidosis, which means the problem is metabolic, so I have written respiratory, and it is acidosis, then we are talking about alkalosis. Clear? Sorry, alkalosis, and the opposite is acidosis. Is that as clear? And whenever there is a respiratory alkalosis, what is the compensation? Again, it is metabolic acidosis. Whenever the component is respiratory acidosis, then the compensation will be metabolic alkalosis. Just reverse it. Vice versa you are doing. Reversing that is the answer. Very good, very good. Many people are answering correct. So now, again, the most important component you remember is about hyperventilation and hypoventilation. So these things are very, very important in clearing your examination, right? So next we are talk about hyperventilation. Consider a patient is hyperventilation. A patient is on hyperventilation, which means, for example, if you can take, you are into the examination hall. You feel so much hyperventilated, right? Like that you feel like so much of hyperventilation. At the time of hyperventilation, what is expected? What will happen in the body? The lungs will do so much of CO2 exhalation, which means excessive amount of CO2 will be going outside when you do hyperventilation, right? So on the other hand, when you talk about hypoventilation, so at that case, my respiratory system is so much declined. For example, if you take a patient of COPD or asthma, or the patient who is in the opioid toxicity, the respiratory system is so much declined. Very good, very good, very good, very good. Yes. So that time what will happen? There will be excessive CO2 retention. The excessive CO2 retention. Right. So here in hyperventilation, the CO2 washout will be there. The CO2 washout will be there. There will be excessive amount of CO2 will be leaving the body. Whereas in hypoventilation, where my respiratory system is so declined, in case of COPD or asthma, in that case, what will happen? The CO2 will be accumulated inside my lungs. As I said you about the base and acid component, I think you're very clear. So CO2 is an acid component, as I said you. If CO2 is going to be accumulated more in the body, it causes acidosis. So hypoventilation will cause respiratory acidosis, whereas hyperventilation will cause right? So hypoventilation, what it will cause? Now tell me in the comment box what hypoventilation will cause. When there is excessive, when there is excessive amount of CO2 is accumulated in my body, what it will cause? It causes acidosis. When the excessive CO2 is exhaled out, at that time the patient will get alkalosis. So this is very, very important to note it down, and we will go to the see, there is some confusions here. Wait. See, in case of hyperventilation, there will be excessive CO2 which is washing out, which is going to cause alkalosis. And in case of hypoventilation, there is excessive amount of CO2 which is retained in the body, which is going to cause acidosis, right? So let's see the next important thing. So here, what is the picture which is given here? It is your Allen's test. It is your Allen's test. See children, please be very clear. Remember, yes, yes, very good. So remember about Allen's test. So Allen's test is a very, very important test which we are doing in order to see in hyperventilation, there will be excess amount of CO2 will be going outside the body, which means outside the body, so that the CO2 retention is very less. And in hypoventilation, what is happening? There will be more amount of CO2 which is accumulated in the body. The CO2 is more in the lungs. So hypoventilation will cause acidosis, whereas hyperventilation will cause alkalosis. Just remember, as I said you, CO2 is an acid component. When CO2 is going to be more accumulated inside the body, that is going to cause acidosis. Okay, when CO2 is not that much retained, in that case, the body will go for alkalosis. Right? Yes. Yes. Please remember, as I said you, the base component and the acid component. Suddenly you people confused me once again. See, listen. Base component, as I said you, your bicarbonate is the only base component, whereas acid component is your hydrogen as well as your CO2. So when CO2 is getting accumulated more inside the body, what will happen? Obviously the acid component is going to increase, so it is going to lead to acidosis. When CO2 is it is exhaled. In that case, there is no CO2 in the body, the acid level is getting reduced, so the patient will go for alkalosis. So this is very simple and you have to understand this. Right. So next, coming back to the Allen's test. Allen's test is one of the most important tests which is used to identify the collateral circulation of your hand. Right? The collateral circulation of your hand. Right? If you talk about Allen's test, whenever you are approaching the radial artery for the ABG sampling, at that time you have to perform this Allen's test in order to identify whether, if at all there is a thrombosis in my radial artery, my ulnar artery will work properly or not. My ulnar artery is working good, so that the circulation is very much fine to go with. So that is the component behind this. So Allen test is basically done in order to identify whether the collateral circulation is present in my limbs, lower limbs or not. Right? So next is, what is the first step? Right? The first step is, you will be asking the patient to clench his fist. Okay. Okay. You will be asking the patient to clench its fist. So Sharma, like the angle of wrist in ABG. The most important question, and the repeat, like it was the last time, NORCET question also. Just remember, ABG analysis or any procedure, even the PTCA which you are doing in your radial artery, the optimal wrist angulation is 45 degree. The optimal wrist angulation or wrist position is 45 degree, right? The 45 degree is the optimal wrist angulation or procedure before performing any kind of procedure through radial artery. Because it was my research, so 45 degree is the correct answer, right? You should not take any other answers, right? So next, coming back to the Allen's test, so what you're doing, you know this is your radial artery which is going and this side is your ulnar artery, right? So you're asking the patient to clench his fist and you're occluding both radial, okay, both radial and ulnar artery, right? You're occluding both radial as well as ulnar artery. Radial as well as ulnar artery. So after a few minutes, Like, you are asking the patient, after few seconds, you are asking the patient to open the wrist, and you can see the paleness in the patient's wrist, right? You can see the paleness in the patient's wrist. So once you see this paleness, what will happen? Immediately you have to release the ulnar artery. You have to release the ulnar artery. You have to release the ulnar artery. Once you release this ulnar artery, when there is a proper redness, like proper circulation, the collateral circulation is established properly, in that case you are coming to the conclusion, even though if there is some thrombus or occlusion is happening because of the procedure in the radial artery, right, in such cases also the ulnar circulation is very much prominent and proper. And that too you have to remember, in less than 15 seconds, in less than 15 seconds, this collateral circulation has to be established. Right? This is your Allen's test, and you have learnt about two important things. 45-degree wrist extension is very, very important before performing any procedures through your radial artery, and followed by, right, and followed by, you have to remember about Allen's test. What is Allen's test? First is pinching of the wrist, then followed by you asking the patient to open the wrist where you can see the paleness. Then you will be slowly releasing the ulnar artery, and you will be finding whether there is proper circulation or not. And meantime, you are clenching your radial artery only, you are not releasing the radial artery. Right? So this is also very, 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 very important to note. Right? So next, again, this is very, very important table. You have to remember, in case of respiratory acidosis, as you all know, the PaCO2 level is going to be increased. See, just now we have discussed regarding this thing, right? So as I said you, when the PaCO2, there is excessive accumulation of your CO2 in the body, will cause respiratory accumulation, like respiratory acidosis. So the compensation is obviously, if it is a respiratory acidosis, the compensation is metabolic alkalosis. As you all know, respiratory opposite, metabolic same, right? So what is meant by metabolic same? The pH also has to increase, and your HCO3 is also going to increase. So here the compensatory mechanism is increased HCO3. Again, the most important key point which you have to remember is, whenever we talk about compensation, the renal compensation happens quite delayed. The renal compensation happens delayed. But your respiratory compensation will happen instantly. Okay, your respiration component happens so easily, but your renal compensation happens so much delayedly. So that is again a most important point you have to remember. And here you can see the highlights, the key associated conditions. If you talk about COPD, that is the combination of both your chronic bronchitis and emphysema, where the patient will be having hypoventilation, impaired ventilation the patient will be having. Because of impaired ventilation, there will be excessive CO2 accumulation in the lungs. This is going to cause acidosis. Remember this thing, CO2 and hydrogen are acid components. This is very, 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 very important to be noted. Right? Yes. So, as you all know, COPD patients and all respiratory patients, respiratory-related condition patients will be having hypoventilation. Right? So remember, chronic bronchitis and emphysema, respiratory depression in case of opioid poisoning, like opioid toxicity. Whenever like morphines and such drugs, when it is reaching its toxicity level, the patient will go for hypoventilation. At that case also, the patient will be going for respiratory acidosis only. This is very important to be remembered. And followed by any form of CNS trauma, like the patient is having a severe form of head injury. Okay, strike fall. At that time also, there will be disruption in the respiratory signals, and patient will go for respiratory distress, and he will go for hyperventilation followed by respiratory acidosis. And any form of airway obstruction which is causing impaired gas exchange and accumulation of excessive CO2, and neuromuscular disease where there is a high risk of respiratory muscle paralysis, right? Like your myasthenia gravis and your Guillain-Barré syndrome, right? This is again very, very important point. And if you want, you people also can contribute that what are all the additional components which is coming under respiratory acidosis. So next we will talk about your respiratory alkalosis. So in whichever conditions there is hypoventilation, in whichever conditions, sorry, okay. So next we are going to talk about your respiratory alkalosis, where the PaCO2 level is going to be so much declined. The PaCO2 level is going to be so much declined. So when the PaCO2 level will be so much declined, when the patient is going for hyperventilation, when the patient is going for hyperventilation, there will be excessive active ventilation and the patient will be struggling and he will be doing hyperventilation like that. So in that case, obviously there will be excessive elimination of the CO2, which in turn is going to cause CO2 washout. CO2 washout. Right. So again, coming back to respiratory alkalosis. So what is the compensatory mechanism? Respiratory opposite is metabolic, and alkalosis is acidosis. Alkalosis is acidosis, right? Alkalosis is acidosis, right? So metabolic, you know, it is same. So what will happen? Metabolic acidosis, what will happen? The pH will be reducing. So when will you diagnose the patient is going for metabolic acidosis? Obviously, if pH is going in downward direction, the HCO3 will also go in downward direction. Here where you can see the compensation, where the HCO3 will be reduced in the compensatory phase, right? So in what are all the conditions the patient will be having hyperventilation? In what are all the conditions the patient will be having hyperventilation? Remember, if I'm in an excessive anxiety and panic attack, where I'm so much afraid of something, at that time I will be hyperventilating myself. Excessive anxiety and panic attack. And remember children, this is asked in your MCQ. And anxiety, in case of anxiety, what kind of metabolic abnormality, what kind of acid-base abnormality the patient will be getting? In anxiety, I will go for hyperventilation. That in turn going to reduce my PaCO2 level in the body, which is going to cause me respiratory alkalosis, which means CO2 is an acid component. I'm releasing excessive CO2 from my body. So what is happening? I am becoming alkalic. I'm becoming alkalic. So next is when the patient is going for high altitude where the respiratory system is overstimulated, in case of fever, in case of sepsis, and salicylate poisoning. And in the early phase and mechanical overventilation, when you're hyperventilating the patient, that time also the patient will go for respiratory alkalosis. So that is very, very important to be noted. So next, we will go for the next important condition. That is your metabolic acidosis. Your metabolic acidosis. As you all know, metabolic components go in same direction. So the pH is going to reduce. So obviously what is happening? The HCO3 is also going to reduce, which is given here. So what is the opposite mechanism or compensatory mechanism which is happening? Now tell with me, what is the compensatory mechanism which is happening? The compensatory mechanism which is happening is metabolic, so it is respiratory. So acidosis, it is again what? Alkalosis. Right? Acidosis, so it is alkalosis. So in respiratory alkalosis, what is the finding you will see? The pH is increasing, and you all know respiratory opposite, metabolic is equal. When the pH and PaCO2 is moving in reverse direction only, we are diagnosing the patient as a case of respiratory alkalosis. If pH is increasing, obviously in respiratory state, the PaCO2 the PaCO2 is going to decrease, right? So here again, coming back to the compensatory state, here you can see the PaCO2 is reducing. That is the compensatory mechanism which is happening here. The PaCO2 is reducing, that is the compensatory mechanism which is happening. So now we will talk about the key associated clinical conditions which is involved in metabolic acidosis. Please remember, in metabolic acidosis only, in order to identify the cause of metabolic acidosis, we are calculating this anion gap, right? To identify the cause of metabolic acidosis, to identify the cause of metabolic acidosis only, we are using anion gap. In other conditions, we are not using anion gap, but only in metabolic acidosis, in order to identify the exact cause of your metabolic acidosis, we are using anion gap. That is very, very important to be remembered. Right. Now tell me, what is the formula for your anion gap? What is your formula for your anion gap? That is your sodium. Okay, sodium. Yes, that is the sodium, which is a cation, and minus your chloride plus your HCO3, right? This is the formula. So as you all know, sodium is a cation, whereas chloride and HCO3 is an anion. So why we are specifically asking sodium, why we are specifically calculating with the help of sodium, chloride and HCO3 is, so chloride and HCO3 are the major anions, okay, like identifying their concentration will give the abrupt value. Same way, sodium is a major cation. So these two are anions and this is the cation you have to remember. Just remember the formula, that is very important. So it is sodium minus chloride plus your HCO3. So remember this thing, anion gap is only done in case of metabolic acidosis to identify the cause of metabolic acidosis. Okay, don't confuse yourself with other things, right? So next, what is the normal anion gap? Now tell me in the comment box, what is the normal anion gap? Yes. Now tell me in the comment box, what is the normal anion gap? Fast, fast, fast. Now tell me, what is the normal anion gap? I'm waiting for your comments. Very good, very good, very good, very good, very good, very good. Many people are answering correctly. Yes, 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 yes. It is 6 to 12. It's 6 to 12. In some books, it is varying, but the standard answer is 6 to 12, right? Your anion gap normal value is 6 to 12. So here we have certain conditions which is going to have more anion gap and normal anion gap in metabolic acidosis. So if you talk about the high anion gap, what is the reason for high anion gap? That is your diabetic ketoacidosis. In case of diabetic ketoacidosis, what is happening? Because of excessive ketone bodies, the acids are accumulated inside the body, which in turn going to cause you metabolic acidosis. Next is lactic acidosis. Obviously, acid production, which is going to cause metabolic acidosis. In case of renal failure, in that case also, there will be what? There will be metabolic acidosis. In case of methanol, ethylene glycol and salicylate poisoning, in that case also, you will be having metabolic acidosis. So the normal anion gap will be seen in case of diarrhea. So why diarrhea is coming under your normal anion gap? See, in diarrhea, what is happening, children? There is excessive loss of bicarbonate. There is excessive loss of bicarbonate, which is leading to metabolic acidosis. That you have to keep in mind. In diarrhea, there is excessive loss of base, that is your bicarbonate. So obviously, the patient will be going for metabolic acidosis, right? Like the base is more, okay, the base is lost. So that's why the patient is going for metabolic acidosis. In case of renal tubular acidosis, okay, in case of renal tubular acidosis also, the patient will be having normal anion gap metabolic acidosis. In case of your mefenide acetate application, as we studied this in burns, it is an important management of burns where we are using this. Okay, in burns where we are using this particular dressing material, that is your mefenide acetate, it causes metabolic acidosis. Those who have attended the last class, they can able to identify that mefenide acetate's important side effect is metabolic acidosis, right? Whenever the alkaline is lost, when the base is lost, the HCO3 is lost. As I said, HCO3 reabsorption is happening in the kidney only. When there is a problem in the kidney, there will be excessive base loss, that is HCO3 loss. In diarrhea also there will be excessive HCO3 loss, which is going to lead the patient to the acidotic state, that is termed as your metabolic acidosis. Base loss is there. Remember, base loss is there, right? Yes. In diabetic ketoacidosis, we will be having Kussmaul's respiration, which is a very, very important find. Next, we are going to talk about metabolic alkalosis. In metabolic alkalosis, as you all know, respiratory opposite, metabolic same. So, when the pH is increasing, the HCO3 is also going to increase, right? That is the finding. So, what is the compensatory mechanism? What is the compensatory mechanism? What is the compensatory mechanism? The compensatory mechanism is, for metabolic acidosis, it is metabolic alkalosis, it is respiratory acidosis. It is respiratory acidosis. Clear? Always you know that respiratory is opposite. If pH is going to decrease, your PaCO2 is going to increase. So that will be your compensatory factor which is happening. Your PaCO2 is going to be increased. So that's how you have to identify and answer the correct answer. Right? Now coming back to the metabolic alkalosis, what are all the clinical features? Like what are all the conditions which is associated with metabolic alkalosis? First is vomiting. In vomiting, what will happen? I am just vomiting, continuously vomiting. Excessive acid is lost from my body, which is going to cause decline in the acid level in my body and lead to alkalosis. And in case of your nasogastric suctioning, I'm keep on doing a suctioning and removing all the stomach acids, which is going to decline in the acid level and lead to metabolic alkalosis. In case of diuretic therapy, such as your loop and thiazide diuretics, in that case also, there will be metabolic alkalosis. In case of hypokalemia and in case of your hyperaldosteronism. See, remember, another one important component, potassium interaction is very important. See, whenever we talk about potassium, potassium will increase. Okay, potassium will increase in case of acidosis. Potassium will increase in case of acidosis, whereas potassium will decrease in case of your alkalosis. I will tell you why. See what happened in case of acidotic state. In case of acidosis, you know there will be excessive H plus will be there. Excessive hydrogen ions which is circulating outside. So what will happen? This excessive hydrogen ion will be shifting inside the cells. Will shifting inside the cells. And it will replace the potassium outside. Right? It will replace the potassium outside, which is causing hyperkalemia. Which is causing hyperkalemia. To maintain that neutralization, when the hydrogen ion is going inside, the potassium is coming outside, to maintain the neutrality of the cell. To maintain the neutrality of the cell. So on other hand, when we talk about alkalosis, here, there is very less hydrogen outside. The very less hydrogen outside. So what happened? Only 1 or 2 hydrogen is there. So what happened? This hydrogen is coming outside to maintain the acidity. The hydrogen ions are coming out of the cells to maintain the acidity. Right? The hydrogen ions are coming out of the cells to maintain the acidity. So what will happen? To maintain the neutrality inside the cell, the potassium will go inside. The hydrogen will come outside and potassium will go inside to maintain the neutrality. That's why when we monitor the electrolyte, the patient will be having hypokalemia. Hypokalemia. This is again an important interaction you should remember, my dear children. Right? This is again a very important interaction you should remember between your hyperkalemia and your acidosis. See, listen, hyperkalemia, you will have acidosis. In case of alkalosis, you can see hypokalemia. Okay, that is what is explained above. So next, we will go and solve MCQs here, where the rapid fire is going to start. Everyone is going to answer with fire, and whomsoever is answering fast and furious will be definitely given with a compliment from my end. Right? Yes. Come on, let's start to solve the MCQs. We have around 25 MCQs for the day to discuss with, and you people will not do any mistakes from now on ABG. Right? So let's start the MCQ series, and this is the first question. You can start answering in the comment box. Yes. Very good, very good, very good. Very good, Divya. Very good, Sharma. Very good, Divya Bharatwaj. Mohit, bipolar disorder. What is the name, man? Sonika, Priyanshu, Batishpa, Priya, Rajkumari, Ramya, Muva, Maina, Priyanka. Very good, very good, very good. So let's solve this for the students who are idle. Right? So the pH normal is 7.35 to 7.45. So here you can see the pH is reducing, right? And the PaCO2 is 60 mm of Fg. The normal is 35 to 45. Obviously, the PaCO2 level is increasing. We are coming to the conclusion, since excessive accumulation of PaCO2 is there, it is a respiratory problem. But we will use our rules only to get a correct, accurate answer, right? So when pH and PaCO2 is going in reverse direction, it is a respiratory problem. It is a respiratory problem. So then we are identifying the pH is less. So it is your respiratory acidosis. It is your respiratory acidosis. So B is the correct answer. A big round of applause to all the students who have answered it correctly. So next. The next question is ready, dear children. Yes, come on. A young female present after repeated episodes of vomiting for 2 days. And when we talk about vomiting, we might have concluded the baseline thing, right? There will be excessive acid loss, which is going to cause metabolic alkalosis, right? But, oh my God, I said the answer. Yes, I'm waiting for you people's answer. Yes, 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 yes. Fast and furious. Priyanka, Divya, Rimpa. Very good, very good, very good, very good, very good, very good. Ramya, very good. So it is your metabolic alkalosis. See, initially you should remember in vomiting, as I said you, there will be excessive acid loss. So if there is excessive acid loss, the patient is going for alkalosis state only. Alkalosis state only. And again, we are coming back to from the baseline data, we are coming to the numerical data. So the pH, what is 7.35 to 7.45, and it is increased pH, so alkalosis. And then you have to talk about your PaCO2 level, that is 35 to 45, and the PaCO2 is also increasing. When pH and PaCO2 are going in same direction, I said you have to remember this hymn, and the problem is metabolic, so the answer is metabolic alkalosis, right? So next we will go to the next question. A patient with severe anxiety, in case of anxiety the patient will be having hyperventilation followed by CO2 washout, right? Now tell me, with the help of the ABG findings, what is the correct answer? The pH is increased again. The PaCO2, it is again, what's happening? The PaCO2, it is 35 to 45, it is decreasing. So when it is going in reverse direction, as you all know, it is a respiratory problem, and the answer is respiratory alkalosis. Very good, very good. So who answered this so furiously? Who is the first rank? Sharma, your Glidapon, Krishna, Anishwa, Priya, Priyanka Batra, Ramya, Rajkumari, Sonika, Divya. Very good, very good, very good, very good, my dear children. Very good. See, hereafter this, I will be increasing the intensity of the question to be from basic to advanced to test your knowledge level. So yes. Now tell me, what is the answer for this question? A 55 years old male with chronic bronchitis has the following ABG. The pH is 7.38, the PaCO2 is 56 mm of Hg, the HCO3 is 31 milliequivalent per liter. Now tell me, what is the correct answer? Yes, people started answering correctly. Sharat, Sandhya, Divya, Priyanka Batra, Divya Bharatwaj, Sonika. Very good, very good, very good. See, the answer is chronic respiratory acidosis compensated. So here you can see the pH 7.35 to 7.45. So it is in the normal rate. And the PaCO2, the normal is 35 to 45, but it is quite higher. Right? And the HCO3 is 22 to 26, which means the kidney is trying to compensate, and it has completed its compensation. That's why it is 7.38. So now you can see the correct answer is chronic respiratory acidosis, which is compensated whenever the pH is normal. Close your eyes and think about compensation. Right? So the next MCQ. A 40 years old female with severe diarrhea has the following ABG. The pH is 7.28, the PaCO2 is 28 mm of Hc, the HCO3 is 15 milliequivalent per liter. Now come on, put your answers in the chat box. Yes. Yes, again, very good. Batinshpa, Nikiranan, Neha Kiran, Manoranjita, Roma, Swati, Neha Kiran, Sonika, Joy, Sandhya, bipolar disorder. Hare, change your name na, bhaiya. Name na, dear, bipolar. Huh? Yes, very good, very good. So it is metabolic acidosis with respiratory compensation. Now tell me, either hypoventilation or hyperventilation is happening here. Critical question. Hypoventilation or hyperventilation is happening here. I want to answer for this. For the students who are at the baseline, you have to listen. 7.28, which means the pH is reduced. The pH is reduced, and the PaCO2. The PaCO2 normal level is 35 to 45, and the PaCO2 level is also increased. When the pH and PaCO2 is going in same direction, so what we are doing, it is a metabolic problem. It is a metabolic problem. And you can also see the pH is reduced, so it is acidosis. On the other hand, I have given you the baseline data. Diarrhea, in case of diarrhea, there will be excessive bicarb loss. There will be excessive HCO3 loss, which in turn going to cause metabolic acidosis. Metabolic acidosis. And the patient is going for metabolic acidosis, and the respiratory compensation has been started to maintain the level. So now tell me what kind of mechanism is happening. Yes, very good, very good, very good. Hyperventilation is happening. Hyperventilation is happening. See children, remember, metabolic acidosis. Metabolic acidosis. Okay, metabolic acidosis. What is the compensatory mechanism? It is respiratory alkalosis. Respiratory alkalosis. So in case of respiratory alkalosis, what will happen? What will happen in case of respiratory alkalosis? Whomsoever answering hypoventilation, it is incorrect. Hyperventilation is correct. Metabolic acidosis, opposite compensation reaction is respiratory alkalosis. When there is hyperventilation, if you talk about hypoventilation, what will happen in hypoventilation? CO2 will be retained inside the body. When CO2, which is an acid component, which is going to be retained more in the body, I will go for acidotic state, not alkalosis state. Right? Already the patient is in acidemia. If I'm doing if the patient compensatory mechanism is hypoventilation, even more carbon dioxide is going to accumulate in the blood, and it is going to even worsen the condition. The respiratory compensation which is happening here is hyperventilation, which means my aim is to reduce the CO2. My aim is to reduce the CO2. Very good. My aim is to reduce the CO2. That's why your hyperventilation is correct answer. Please remember children, even like if at all you get in confusion, as I said you, think about metabolic acidosis, the exact opposite is respiratory alkalosis, I said you, right? The exact opposite is for metabolic respiratory acidosis, alkalosis, I said you. So in respiratory alkalosis, there is excessive alkaline, excessive base. Okay, when the case is excessive base, when I'm doing hyperventilation, what will happen? CO2 will be washing out. There will be no acid accumulation. Your carbon dioxide will be accumulated as your carbonic acid. In case of hyperventilation, my carbon dioxide is not going to accumulate. It is going to be, let it out, enjoy. But in case of hypoventilation, carbon dioxide is going to sit inside my lungs, which is going to cause excessive acid accumulation. So here, when the patient is already in the case of metabolic acidosis, I expect the respiratory compensation, the normal compensation which is going to happen is hyperventilation. Remember this. If it is not clear, please put in the comment box. I will repeat it once again, but never ever confuse in this case. I said you base component is HCO3 and acid component is CO2 and hydrogen. CO2 is released outside with the help of your lungs, and H+, which is the acid component again, which is released with the help of your kidney. Again, HCO3 reabsorption and balance maintenance is done by your kidney. Right? So please put in the comment box it is crystal clear or not, or else I will repeat this MCQ. Yes, yes, put in the comment box. Okay, I will repeat it once more. So, highly active students, please be patient for very few minutes. Let me complete this concept and you will also reinforce your learning and I will do. So Priyanshu and Anishwa, I'm repeating for you people, dear. Right? So I said about hyperventilation. Hyperventilation. So what is mean by hyperventilation? Normal ventilation is normally you inhale and exhale. Hyperventilation is rapidly, like that you are doing a rapid ventilation. When you do rapid ventilation, the CO2 will be washing out. You will be expelling and exhaling more amount of CO2 outside. Okay, which is going to cause CO2 wash out. And the most important basic point I said you is CO2 and hydrogen or acid components. CO2 and hydrogen or acid components. Whereas your HCO3 is a base component, right? So if CO2 is getting washed out more from my body, will I go for acidosis? The acid is not accumulated, carbonic acid is not accumulated in my body. So obviously I will go for alkalosis. The patient will be going for alkalosis only, right? On the other hand, if you think I am doing hypoventilation, when I am going for hypoventilation, what is happening inside my body? I am doing a very, very shallow breathing. In case of COPD or asthma patients where they are using very shallow breathing, their airways are impaired and there will be excessive CO2 accumulation. As I said you, CO2 is an acid component. Obviously, when CO2 is going to be so much accumulated inside my lungs, I will go for acidotic state. Now it is clear, dear Anishwa and Priyanshu. And again, I'll come back to the question. So as I said you, metabolic acidosis, the exact compensatory mechanism which is happening is, I said you, in case of metabolic, it is respiratory. And if it is an acidosis, then you have to write alkalosis, right? In case of alkalosis, what is happening? Coming back here. In case of alkalosis, hyperventilation is happening, where the patient will be hyperventilating himself, whereas they will be washing out more amount of CO2, and the acids are released from my body to recover me from this metabolic acidosis, right? Very good. Very good. Now it is clear? Yes, fine. So the answer is metabolic acidosis with respiratory compensation. Obviously, if it is alkalosis, hyperventilation is happening, not hypoventilation, dear children. A very, very important point you have to remember. Yes, the next question. Okay. A 30 years old woman with recurrent vomiting present with the pH of 7.49, PaCO2 48, HCO3 30 milliequivalent per liter. What is likely the interpretation? Now tell me, what is the correct answer? Again, the answer is B. B is the correct answer, which is metabolic alkalosis with respiratory compensation, right? So here you can see pH is 7.35 to 45 and it is increased. pH is increased and PaCO2 is 48. That is also increased when they are going in same direction, and vomiting is also supporting, which is water loss, right? Vomiting is also supporting, which is water loss. Hi Shrikant, how are you? Shrikant is my student of SRMC. Hi, how are you Shrikant? Very good to see you in the live class. Yes. Coming back to the class, so your PaCO2 is also increasing, and your HCO3, the normal is 22 to 26, and here it is again is increased. Right, so the component and vomiting is supporting the patient is going for excessive acid loss, which is going to add a value, and you are going to come to the conclusion it is metabolic alkalosis. Now tell me, if metabolic alkalosis is there, the patient is going for hypo or hyperventilation. So metabolic alkalosis, the compensation of metabolic alkalosis is respiratory acidosis. Right. So if the patient is going for respiratory acidosis, either he will be having hyperventilation or hypoventilation. Very good, very good, very good, very good. The patient will be going for hypoventilation. Ma'am, full compensation or partial compensation in this question? The before question or this question? See, if you see, none of the values is normal, right? The respiratory compensation has been started, but the pH is not been in the normal level, and your HCO3 is also not in the normal level, and your PaCO2 is not in the normal level. This is in the process of partial compensation. This is in the process of partial compensation, right? It is not either fully compensation or an uncompensated case where the respiratory system is not doing any action. It is a partial compensation question, right? So next, we will go to the next question. And ABG showing 7.32, PaCO2 30 mm of Hg, HCO3 is 16 milliequivalent per liter. What is the interpretation? Again, here where you have to use your full knowledge and answer me this question like a rapid fire. What is the correct answer? So the pH, if you see the pH 7.35 to 4.5, it is decreasing. Your PaCO2, that is 35 to 45, again, both are going in same direction. Both are going in the same direction. So it is indicating it is a metabolic problem. And HCO3 is dreadfully reduced. So it is metabolic acidosis. Metabolic acidosis. So we will talk about our step 4. Okay. Our step 4. Very good. Many students have started answering correctly. Now we will talk about our step 4. In metabolic acidosis, if the problem is metabolic, we have to see the PaCO2 level. Right? We have to see the PCO2 level. Sorry. We have to see the PCO2 level. So if the PCO2 level is normal, we are terming it as uncompensated. If pH is becoming normal, you are telling it as fully compensated. If pH is not normal, you are telling it as partially compensated, right? So here the pH is not normal, okay, but the respiratory compensation has been started, right? So it is a metabolic acidosis partially compensated is the correct answer. Metabolic acidosis partially compensated is the correct answer, right? A very good applause to the students who have answered correctly. That is your Priyanka, Priyanshu, Mano, Swati, Sonika, Divya, Robini, Rajkumari, Ruma, Banteshpa, Joy, Parvata, Shrikant, Sharma, Priya, Ramya, Priyanshu, Anishwa. Very good. So let's, with the same N2, we will go to the next question. Yes, now it starts your rapid fire. Now tell me what is the answer for this MCQ. The ABG shows pH 7.25, PaCO2 45 mm of Hg, HCO3 17 milliequivalent per liter. What is the interpretation? What is the interpretation? Let's solve this. pH is reduced. PaCO2 is 35 to 45. It is maintained a normal case. And HCO3 is 17 milliequivalent per liter. Right. So here, what is the primary condition? Since the HCO3 level is so much decreased, you remember about Rome. And you can also apply your PaCO2 reverse direction, pH PaCO2 reverse, and pH PaCO2 same direction also you can apply. But the PaCO2 is normal, but you can see the HCO3, the bicarbonate level is very much declined. Then you are coming to the conclusion. It is a metabolic acidosis. It is a metabolic acidosis. So coming back to our step 3 classification or clarification. So here the problem is metabolic, so you have to see the PCO2 level again. The PCO2 level, if it is maintained normal, it is uncompensated. If pH is normal, it is fully compensated. If pH is not normal, it is partially compensated. So here you can see the PaCO2 is maintained so normal, which means the respiratory system is not doing any action in order to do the compensation and to maintain the acid-base state. So the answer is uncompensated metabolic acidosis. The answer is uncompensated metabolic acidosis. No, dear children, it is not partially compensated. It is uncompensated metabolic acidosis. Since you can see the PaCO2 level is maintained in the normal state, even if the HCO3 is reduced this much, which means the respiratory system is not taking any action in order to reduce, in order to increase the pH level, right? So next we will go to the next question. ABG is showing pH 7.47, PaCO2 50 mm of Hg, HCO3 34 milliequivalent per liter. What is the interpretation? Now answer in the comment box. What is the interpretation? Yes, Priyanshu, come on, answer. Yes, yes, yes. 7.47. Okay, it was an error. Just, I'm removing your A option. Now answer me. Yes, now answer me which is the correct answer. Yes, obviously A and D both are correct answer. That is your metabolic alkalosis with your partial compensation. So since I removed A, so your D will be your correct answer. Very good, very good, very good. See, people are answering C, B and all. That is not at all a correct answer. See, listen, coming back to our state. So the pH 7.35 to 45, it is increased. It is, pH is increased. pH is increased. Then what about your PaCO2? That is 35 to 45. Again, it is also increased, right? And coming back to your HCO3 level, that is 22 to 26, that is also increased. If pH and PaCO2 is going in same direction, the problem is metabolic, and with the help of your pH, you can tell it is a metabolic alkalosis. Metabolic alkalosis. So when the problem is a metabolic problem, then you have to see your PaCO2 level. So when PaCO2 is normal, it is uncompensated. When PaCO2 is normal, it is uncompensated. When pH is normal, it is fully compensated. When pH is not normal, it is partially compensated. Right? So here we will come back to the question. So if you see, the pH is trying to be normalized. It is coming to the near normal level, which means in the metabolic alkalosis state, the PaCO2, the respiratory compensation, has been activated, right? So the correct answer is your metabolic alkalosis, which is partially compensated. So now we will go to the next clinical based questions for your ABG. A patient with chronic obstructive pulmonary disease present with drowsiness, dyspnea, and ABG showing pH of 7.30, PaCO2 of 58 mm of Hg, HCO3 26. What is the priority nursing intervention? Now answer me like a pro for this particular question. See children, obviously the clinical correlation, COPD means the patient is on respiratory acidosis, which means because of hypoventilation, because of the preceding condition, and the patient is going for hypoventilation, which is leading to what? Which is leading to respiratory acidosis. So if the patient is on respiratory acidosis, okay, what is happening? There is excessive CO2 inside the lungs. So encourage deep, rapid breathing using a rebreather mask. So this is going to further worsen the condition because it will cause fatigue, and even more amount of CO2 can be retained in the lungs. So administer high flow oxygen at 10 to 15 liter per minute via a non-rebreather mask. If you are going to do so, as you all know, these COPD patients will have the hypoxic drive. They have an hypoxic drive, which means the sensing of the respiratory center for the minimal hypoxia will make the patient to breathe in a normal pace. So if you're going to administer more amount of oxygen with the help of a high flow mask, this is going to decline this hypoxic drive and further worsen the condition of the patient. Right? So this is not advised. So assist with pursed lip breathing and provide low flow oxygenation. This is the required treatment. When we are going to instruct the patient about pursed lip breathing is going to prolong your exhalation, which is going to increase the duration of the exhalation. When the patient is doing an increased, like more amount, like we are increasing the amount of exhalation, what will happen? The CO2, okay, the CO2, okay, it will reduce the CO2 level. Okay, if you're going to prolong the exhalation process, it is going to reduce your CO2 level. That's why your pursed lip breathing is very much important. Your pursed lip breathing is very much important. So low flow oxygenation you are going to administer to the patient, because what will happen if you administer a low flow oxygenation of 1 to 2 liter, okay, 1 to 2 liter. So what will happen? This is going to maintain that hypoxic drive and make the patient to breathe properly. Okay, this drive will be keep on there, and the patient will initiate his own breathing. So restrict fluid intake to prevent pulmonary edema. This is not that much advised, and that is not a priority nursing intervention. The priority nursing intervention is teaching the patient regarding the pursed lip breathing and prolonging the exhalation. Thereby the CO2 retention is reduced. The CO2 retention is reduced. Right? So C is the correct answer. So next we have the next question. A patient present with lightheadedness, numbness around the mouth, and ABG showing the pH of 7.50, which is increased, your PaCO2 is 28 mm of Hc, and HCO3 is under normal level. So what is the priority nursing action? Now tell me, what is the priority nursing action? The patient is in the case of when pH, if you talk about pH, it is increased, and PaCO2, it is decreased. When they are going in reverse direction, the condition is what? The condition is what? Yes, very good, very good. Many people have started answering correctly. Yes. Right? So the patient is going for respiratory acidosis. Sorry, respiratory alkalosis. So in this case, what is the management? You have to encourage slow breathing using a paper bag. So here, the patient is in the case of respiratory alkalosis. Right, the patient is a case of respiratory alkalosis. So what is happening? So why we are encouraging the slow breathing using a paper bag? Now tell me in the comment box, why we are using this slow breathing? Yes, very good. Using a paper bag, okay, this allows CO to wash out, thereby we can reduce the preceding condition, right? We can reduce the preceding condition. It can retain some amount of CO2 inside the body, so that is going to promote the patient's well-being. So encouraging slow breathing using a paper bag, when you keep on doing with the paper bag, what will happen? The exhaled CO2 will be again re-inhaled by the patient. Exhaled CO2 will be again re-inhaled by the patient, so that the patient can recover from your respiratory alkalosis state. Okay, the acid maintenance can be done with the CO2 retention. So that's why we are encouraging the patient to slow the breathing using a paper bag. See, remember, the condition which is happening is respiratory alkalosis, as I said you. So in case of respiratory alkalosis, what will happen? What is the cause of respiratory alkalosis? If the patient in hyperventilation or hypoventilation, he will go for respiratory alkalosis. Now put in the comment box immediately if the patient is going for hyperventilation or hypoventilation in case of respiratory alkalosis. Respiratory alkalosis means there is no acid, which means there is no CO2 accumulation, which means the patient is hyperventilating. The patient is on hyperventilation. So here you have to promote hypoventilation to recover from this condition, right? So that's why you are instructing the patient to breathe inside the paper bag, so that he will re-inhale the CO2 in more amount, so that he will recover from the symptoms. So encourage slow breathing with the paper bag is the correct answer. Very good, right? So administer sodium bicarbonate intravenously, no. And place the patient in high follows position, no. Irritate the rapid breathing exercises to increase the oxygenation. Initiating a rapid breathing exercise to initiate the oxygenation is further going to increase the CO2 washout, right? Yes. So the next question, in respiratory acidosis, the serum potassium is usually Yes, am I audible? Yes. Now tell me the answer. Very good, very good, very good. So in respiratory acidosis, serum potassium is usually, as I said you, in case of acidosis, what will happen to the potassium? The cell will be having, outside the cell there will be more hydrogen ions, more and more hydrogen ions, and they try to shift inside the cell, and the cell is having potassium ion which will try to come outside in order to maintain the neutrality. Okay, in order to maintain the neutrality. So the potassium is coming outside, so obviously increased due to the shift of potassium out of the cell is the correct answer. Remember? Yes. Many students have answered correctly. Very good, very good, very good. So next we will go to the next question. What changes in potassium level is typically expected in respiratory alkalosis? So what change in potassium is typically expected in respiratory alkalosis? Yes, I'm waiting for you people's answer. Yes. Again, A. Sharma. See, listen, I have to play with the options, right? Like many times the options is similar and some people are sensing with the help of that also, I think. But in your AIMS examination, this is not the case. Be very careful, right? Yes. So here, as I said you, in case of alkalosis, there will be very much hydrogen ions, which is a base component which is outside. So what happened? Okay, so what happened? These hydrogen ions will try to shift. Okay, so decrease due to potassium shift into the cells. So what happened? This less hydrogen ions will try to shift inside the cells. Okay, inside the cells, and what will happen? See, please. Sorry. See, what is happening in case of alkalosis is there is potassium ions inside the cell and there is very less hydrogen ions outside. So in order to maintain the neutrality, okay, potassium will be shifting inside the cell. The potassium will be shifting inside the cell and trying to put hydrogen outside, which is going to cause decrease due to hydrogen shift into the cell. Potassium will be going inside the cell and hydrogen will be coming outside the cell in order to maintain the acid balance. That is what is happening here. Okay, potassium will try to go inside the cell and hydrogen will come outside the compartment so that it can maintain the acidic state in case of alkalosis. So here in alkalosis state, always remember there will be hypokalemia. There will be hypokalemia. That you have to definitely remember. Is that as clear, or I need to explain it one more time? Let me explain. So here in this case of alkalosis, there will be very less amount of hydrogen which is present outside. Okay, the hydrogens which is present inside the cell, will come outside. The hydrogens which is present inside the cell will come outside in order to maintain the acidity, and the potassium will shift from the extracellular space to the intracellular space in order to again to maintain the neutrality. So in this case, what will happen? Obviously, the potassium shifts. Potassium is shifting inside the cell, which is going to cause what? Decline in the potassium level. So always remember, in case of alkalosis, there will be hypokalemia. Yes, Mr. Vinodan, good. Hi. Thanks. Thank you so much for the compliment. Yes. So next we have another important question. The anion gap is calculated using which of the formula? Now type your answer. Yes, now type your answers. Like the anion gap is calculated using which of the following formula? So as you all know, the correct formula for your anion gap, which is specifically used in order to identify the metabolic cost, right? So the formula is sodium, which is a cation, minus your chloride plus your HCO3. That is the correct answer. HCO3 is the correct answer, right? So where is the correct answer? Your sodium minus your chloride plus HCO3 is the correct answer. Option B is the correct answer. Very good, very good, very good. Very good. Yes. Is it clear? Now we will go to the next question. See here, it is a quite tricky question. Try to attempt it. It will be very useful for your examination. Yes. 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 So a 45 years old man is brought to the emergency department with deep, rapid breathing, Kussmaul's respiration, nausea and abdominal pain. He is known to have type 1 diabetes mellitus, and lab investigations reveals sodium 138 milliequivalent per liter, chloride 96, HCO3 is 19 milliequivalent per liter. Blood glucose, yes, very good, Sharma. Blood glucose is 480 milligram per dl, and the ABG pH is 7.25, PaCO2 is 28 mm of Hg. Now tell me, the pH and PaCO2. pH is reducing and PaCO2 is also reducing. So same direction, it is a metabolic problem, it is metabolic acidosis, right? So again, but you need to calculate the anion gap as well, right? Yes, the answer is A. Very good, very good, very good, very good. Many people are answering correctly. Very good. The answer is A. So let's do workout with the formula, right? Your anion gap, which is specifically used in case of your metabolic acidosis, the formula is sodium minus your chloride plus HCO3. So other values are not required. What is sodium? It is 138 minus what is chloride? It is 96 plus your HCO3 is 12. So 138 minus your 8 plus 108 is equal to 30. Your anion gap is 30, right? Right? So anion gap is 30. 138 minus 108. The anion gap is 30. It is not 20, it is 30. Be clear with the calculations. See, at the time of examination, you will become like, slight panic attacks can happen. It is very common. But it is very, very important to overcome these panic attacks so that only you can achieve whatever you want. Right? Be very clear with whatever you learn. Add value in whatever you learn. Just like that, should not do things so much vaguely, which is going to create a lot of chaos only, right? Be very confident, be very clear in what you learn so that you can depict the same confidence in your examination hall, right? Yes. So the answer is the anion gap is 30 and high anion gap metabolic acidosis, as well as we have seen the Kussmaul's respiration, which is indicating the patient is a case of DKA, right? Yes. So we will go to the next question. Again, a patient with severe diarrhea present with metabolic acidosis. Atrial blood gas shows pH 7.28, HCO3 16 milliequivalent per liter. What is the preferred IV fluid corrections for acidosis? What is the preferred IV fluid correction for acidosis? Yes. Now put your answers in the chat box. What is the preferred fluid for the correction? Wow, very good. Suddenly the answers are coming. Very good, very good. The preferred fluid is your ringer lactate. But why ringer lactate? But why ringer lactate? See, ringer lactate is the correct answer. But why you people are choosing ringer lactate as the correct answer? So ringer lactate contains lactate, okay, lactate, which is metabolized in the liver, metabolized in the liver to bicarbonate, That's why it will help in correcting the acidosis. That's why ringer lactate is the preferred solution. See, ringer lactate is a preferred solution in case of your metabolic acidosis. Why? Because this ringer lactate is containing a lactate component which is metabolized in the liver to bicarbonate. So here we need bicarbonate to maintain that acid-base balance, because acid is less, the base bicarbonate we need. So because of this metabolization and conversion of lactate into HCO3 is very important in order to maintain this case. Metabolic acidosis, very good, because it contains lactate, Ashu, but the most important thing you have to additionally remember is it contains lactate which is metabolized as your bicarbonate by your liver, so that it is producing more bicarbonate and trying to compensate the mechanism. Now, the next question. A patient with persistent vomiting for 3 days presents with ABG showing pH 7.48, HCO3 32 milliequivalent per liter. What is the preferred fluid correction for metabolic alkalosis? Now tell me. Bipolar disorders, NS, yes, very good. Now tell me, like same way, why C is correct answer? As I said you the rationale behind ringer lactate. Now you tell me the rationale behind normal saline. Now you people has to answer me the rationale behind normal saline. See, the patient with metabolic alkalosis will be having excessive chloride and potassium loss. Excessive chloride and potassium loss. This can be recovered. Okay, this can be recovered with the help of your normal saline. So there will be excessive potassium and chloride loss, which can be recovered by administration of your normal saline with potassium, right? Yes. Fluid loss causes potassium loss. Very good, Swati. Please give a big round of applause to her, who has given a valid rationale for the question. So we'll go to the next question. Mefenide acid is commonly used in burns wound care due to its ability to penetrate eschar. However, a significant side effect of your mefenide acid, those who have watched Burns lecture will be having their answer in fingertips for this particular question, right? So now you have to answer me correctly, and those who have not watched Burns lecture, I request you people to definitely watch the Burns lecture before going for examination, because all the updates on burns has been given in that particular lecture. The previous Friday lecture was on burns, so please look into it. Very good, very good, very good. Very good, Manoranchita, Rajkumari, Priyanka, Patra, Priya, Ramya, very good. So the answer is metabolic acidosis, as we discussed very clear in our class. Mefenite acetate, which is one of the important component dressing material which is used in burns patient, has the increased side effect of causing metabolic acidosis. So next we have a match the following question. So now match the following question. First tell me metabolic acidosis. Metabolic acidosis. And I have very important surprise question for you in the last. So definitely you have to be with me till the last so that I will talk about Penile ABG also. Yes. Yes, these kind of questions are very common nowadays. Now I am waiting for you people to answer this question. Metabolic acidosis is seen in case of diabetic ketoacidosis. Yes, correct. Respiratory alkalosis. Respiratory alkalosis is seen in case of anxiety and hypoventilation. Respiratory acidosis is seen in case of COPD. Metabolic alkalosis is matched correctly only. It is prolonged vomiting. So here respiratory acidosis, COPD because of hypoventilation, and respiratory alkalosis, anxiety, hypertensive syndrome. This is induced by hyperventilation. And here metabolic alkalosis because of prolonged vomiting and acid loss. And your metabolic acidosis with the help is caused, the most associated condition is your diabetic ketoacidosis. Very good, very good, very good, very good. So many people have answered correctly. That is very nice. Leela, Rajkumari, Ramya, Anishwa, Manoranjita, very good. So these questions is like, you know, if you attempt one question also, it is indicating that you are attempting 4 MCQs at a time. So these questions are time taking as well as tricky also. If you miss one answer also, it will lead to wrong answers. So that is very important to attend these questions very cautiously. So next we have another question. This is a select all that apply question. A 45 years old male is admitted with severe burns involving 40% of the total body surface area. His ABG shows pH 7.28, HCO3 60 milliequivalent per liter, PaCO2 34 mm of Hg. Which of the following are true regarding this patient's ABG finding? This is select all that apply MCQs. Yes. Come on. Which are all selected. So let's solve this MCQ. pH is reduced. HCO3 is also reduced. PaCO2 is also reduced. So going in same direction, HCO3 is also reduced. It is a metabolic acidosis. It is a metabolic acidosis. Alright, it is a metabolic acidosis. And it is a metabolic acidosis. And the patient has metabolic acidosis, correct answer. The anion gap is likely to be increased. So remember, in case of burns patient, okay, in case of burns patient, the anion gap will be slightly increased only. And the PaCO2 is compensating for primary disturbance. If you can see the PaCO2 level, it is doing a primary compensation. Yes, the PaCO2 level is altered and it is trying to do a primary compensation. Yes. This is a case of respiratory acidosis. Absolutely wrong. Mefenite acetate can worsen the acid-base status. Yes. The patient in metabolic acidosis, so mefenite acid is having an important role. Very good, Anishwa. Very good, Divya. Very good, very good, very good. A, B, C, E except D is the correct answer. Please give a big round of applause to Divya, Rubini and Anishwa. Very good children. And Priyanshu as well. Priyanshu as well. Very good, very good. So let's go to the next question. Which of the following drug may cause normal anion gap hyperchloremic metabolic acidosis? This is again a tricky question. Very good, Priyanka Patra. Again, these questions needs advanced understanding in ABG so that you can clear these MCQs. Yes. Tell me. Mefenide acid is having increased penetration. Okay, it is having increased penetration. So that's why it is causing acid-base imbalance. I'm waiting for the correct answer for this particular question. Which of the following drug may cause normal anion gap hyperchloremic metabolic acidosis? Till now, I have not received the correct answer. Oh my God. No, no. I'm just waiting for the correct answer, giving you 2 minutes to analyze and tell the answer. Yes, yes, skip. Okay, Leela will skip this question. Very safe, very good. See, Priyanka Patra and your Moksha Gundam. Very good. Moksha Gundam, bipolar disorder, medical education. Very good. PH, Moksha Gundam, very good, very good. See, your acetazolamide is an important drug which causes normal anion gap hyperchloremic metabolic acidosis. What is this drug? This is the carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. So what this drug will do? What this drug will do? It reduces the HCO3 reabsorption. It reduces the HCO3 reabsorption, thereby causing metabolic acidosis. Even though the patient is going for acidotic state with decline in the HCO3 level, so what is the compensatory mechanism which happens when we are taking acetazolamide is, the patient's compensatory mechanism will increase the chloride level. That's why we are specifically telling, even though the HCO3 level is reduced, it increase the chloride level and try to maintain. Okay, try to maintain the effect, right? So that's why your acetazolamide, a carbonic anhydrase inhibitor, which reduces the HCO3 level, and it is the one which has a normal anion gap, hyperchloremic. That is also a key point you have to remember for your exam point of view, right? Which of the drug causes hyperchloremic normal anion gap metabolic acidosis? The answer, one and only answer, is your acetazolamide, which is a diuretic drug under your carbonic anhydrase inhibitor classification. Moksha Gundam, very good. Where did you study these things? The students who have answered correctly, please put in the comment box where you people study these things so that the other students also get sensitized. Yes. Yes. The next question. Which is the first compensation mechanism in metabolic acidosis? Which is the first compensatory mechanism in metabolic acidosis? Which is the first compensating mechanism in metabolic acidosis? Come on, come on, I'm waiting for your answers. Come on, come on, come on. New answers, new people, very good. Studied in Nurses Encyclopedia, very good. Very good. Yes, Sharma has highly concentrated and given the correct answer. Yes, respiratory hyperventilation is the primary compensatory mechanism. Yes, as we studied earlier, metabolic acidosis, opposite. compensatory mechanism is oppositely happening. So it is respiratory, it is respiratory, it is respiratory alkalosis. So in case of respiratory alkalosis, what is happening? Your respiratory hyperventilation is happening, so that I need to wash out more CO2. I need to wash out more CO2, which is causing this acidotic effect in my body. I have to do more hyperventilation so that more CO2 is going out of my body, so that I can recover myself from the acidotic state and go for a normal mechanism. Right? Yes. So the next question. Which of the following ABG result is suggestive of a mixed respiratory and metabolic acidosis? These were challenging questions I tried to put because pattern is quite changing day by day. So it is very important to advance ourselves also. Now tell me, which of the following ABG results suggestive of a mixed respiratory and metabolic acidosis? I'm waiting for your answers. Yes. C. C is the correct answer. Now tell me, this is showing mixed respiratory acidosis as well as metabolic acidosis. If you see the pH is less, PaCO2, that is 35 to 45, which is increasing, which is showing a reverse component, which is indicating it is a respiratory acidosis. And again, if you talk about the HCO3, the HCO3 is again decreasing. So pH and HCO3 are going in same direction. So it is always indicating both respiratory acidosis as well as metabolic acidosis. Metabolic acidosis. Now coming back to the other options. So 7.50, pH is increased, PaCO2 is decreased. So reverse direction, the problem is, okay, the problem is respiratory, it is respiratory alkalosis. 7.35 pH is normal, PaCO2 is increased. And so if pH is normal, okay, subnormal, okay, and the PaCO2 is increased, so again it is a respiratory problem, it is respiratory acidosis. So here we have identified option C is mixed problem. In 7.40, so the pH is in normal level, PaCO2 35 to 45 normal level, HCO3 is also normal. So this is not the correct answer. Right? So mixed respiratory and metabolic acidosis also you should have in the mind. Right? So next question. In high flow priapism, so this question is going to be very much tricky for you people. Now tell me, in high flow priapism, the ABG of penile aspiration shows. Now let me see who is the advanced student who is coming up with the answer for this question. In a high flow priapism, ABG of penile aspirate shows what? Yes. Come on, tell me the answer. D. Some people are answering C. Yes. Any other answers? A. Any other answers? Priyanshu is also answering D. Any other ABG findings? Yes. Sharma got my heart. The correct answer is well oxygenated atrial blood. Remember children, when you see a word high flow priapism, what is meant by priapism? Priapism is prolonged erection of the penis, prolonged erection of greater than 4 hours, right, or lesser than 4 hours. In case of, in case of low flow priapism, it will be greater than 4 hours. Here it will be less than 4 hours. Okay, please remember, in case of high flow it will be less than 4 hours, but in case of low flow it will be greater than 4 hours. I have a comparison table, I will tell you. See, priapism is a prolonged erection of your penis. Okay, in that case, what will happen? For the diagnostic evaluation, we will collect the penile ABG. In penile ABG, we will be finding out whether it is a high flow priapism or a low flow priapism. It is obstructive based or it is because of over circulation. So let's see the table which is stating that. So here, high flow priapism, it is non-ischemic due to under-regulated atrial inflow. It is due to under-regulated atrial inflow. And whereas in low flow priapism, it is ischemic because of venous outflow obstruction. There will be ischemic low flow priapism. So atrial blood flow is increased to your corpora cavernosa. So this, especially in penile area, from this particular corpora cavernosa only we will be aspirating the ABG and we will be evaluating. Here, decreased venous drainage leads to venous stasis and hypoxia. So common causes is perineal or penial trauma, eretogenic because of intracavernosal injections and all, and anterior venous fistula. Here, what are the causes in low flow? All coagulating states such as sickle cell anemia, leukemia, and use of vasoactive drugs in case of neurological spinal injury. Post-traumatic, common in children and young adults with hematological coagulative disorders. Here it is painless erection in case of high flow. Here it is painful rigid erection in case of low flow. May persist but less urgent for less than 4 hours. But here for greater than 4 hours and it is an emergency. Penile ABG shows the PO2 high, the PCO2 low and the normal pH. Here the PO2 will be low, the PCO2 will be high and the pH is acidic because of acidotic state. Yes, without your sildenafil citrate, penile erection will be there. Priyanshu, so Doppler's USG increased flow to your cavernosal arteries, you can see, and remember about this corpora cavernosa also. That is, in that place where we are aspirating the thing, and decrease or absent flow of cavernosa arteries are seen. That's all. We have came to the end of this session. So I hope this session was really helpful for you people and you learned certain advanced and new things from this class. No, it's okay, Priyanshu. This is very common, right? See, here also if you tell your sildenafil citrate, if you talk about that, that will be the learning for other students, right? That will be the learning for other students. That is very good also. See, thank you so much for watching the class and please show your support to my Instagram handle, that is my social media handle. Please show your support and please comment your feedback about the class in the comment box so that if I need any improvement, I will do for you people, or if the pace is okay, right? Thank you so much. Many people are commenting very positively. Thank you so much for your comments. Okay? Yes. Please put your feedbacks in the comment box so that I can able to modify or rectify if you need any changes in the classes. So thank you so much for watching. All the very best for your upcoming examinations and do a very good learning without wasting a time, because your NORCET notification is out, the exam date is out. Like, you'll be in a quite anxiety state, but it is all about the strategies and important. For Plan C subscribers, we will be sharing the strategies soon and we will be having a special session. And to be very important to notice, you people are going to have the fast track series of Plan C plus English edition. which is exclusively in English for English audience, the subscribers of Plan C+. So you can make use of those videos in your last minute preparation. So all the very best for your examination. And thank you everyone for your wonderful comments on the class. Thank you so much, Priyanshu, Leela, Sharma, Priya, Swati, Anishwa, Manoranjita, Muva, Priya, Rajkumari, Maina, Pradhan, Divya Robini, Rajkumari, Radraj. Thank you so much. Bye-bye.